Hi, my name is Michelle Armstrong. I'm an RN, LPC, and NCC, and I am going to give a presentation, an episodic SOAP note video presentation on the topic of streptococcal pharyngitis. I'm going to come over here and share my screen with you so that you can follow along as I share this PowerPoint presentation with you. So the chief complaint of the patient in this scenario was that my glands feel swollen. The patient was a 22-year-old white male in his usual state of good health until 2 days ago. He complained of acute onset swollen and tender glands in his neck, sore throat, fever, headache, and malaise. The patient stated that his glandular discomfort and throat soreness were worse in the morning, with fever, headache, and malaise worsening as the day progressed. The patient denied radiation of glandular or pharyngeal pain and headache. The patient stated that his throat discomfort was aggravated with swallowing, but relieved by sucking on Jolly Ranchers and cough drops, drinking nectar, gargling with warm salt water, and running a humidifier. The patient reported that ibuprofen relieved his fever and headache and rest his malaise. The patient stated that he had babysat his 5-year-old nephew 2 days ago, and then the nephew had just been diagnosed with strep. A review of systems with this patient revealed the following data. The patient reported fever and malaise. He denied recent weight changes, chills, sweats, weakness, and fatigue, vesicles or ulcers on palms or soles, and denied the presence of a rash. The patient reported the presence of a headache, but denied excessive tearing, ocular discharge and irritation, earache, and ear discharge, as well as frequent colds, nasal congestion and discharge, sneezing, and sinus trouble. The patient reported a sore throat and dysphagia, but denied ulcerative stomatitis and hoarseness. The patient did report having swollen tender glands, but denied cough, dyspnea, and wheezing, as well as heart trouble, high blood pressure, rheumatic fever, heart murmurs, chest pain, or discomfort. The patient did report having dysphagia, but denied anorexia, nausea, vomiting, and diarrhea, abdominal pain, including periumbilical pain, jaundice, and splenic or liver discomfort. The patient denied joint, muscle, or body aches, denied scapular and back pain, and also denied having a history of depression or treatment for any other psychiatric symptoms. The patient did affirm that he had a headache. The patient's active medical history includes symptoms noted in the history of his present illness and are isolated to those, including complaints of an acute onset swollen and tender glands in his neck, sore throat, fever, headache, and malaise. The client's past medical history reflects a lack of a denial of scarlet and rheumatic fever and denial of chronic childhood illnesses. The patient denies the presence of chronic disease, denies having had surgeries, and denies treatment for any psychiatric conditions. The patient stated that he has been using ibuprofen 200 milligrams, but taking it by mouth every 6 hours for the past couple of days. He also denies the use of other medications, home remedies, vitamins, minerals, and supplements. The patient states that he has no known allergies. The patient stated that he had received his childhood immunizations and that he had received a flu vaccine in November of 2016, but that he had received no other immunizations. The client was screened for TB in October of 2016, and the screening was negative. The client denies a family history of headache or rheumatic fever. The client states that he is single, not in a relationship, is a pre-medical student, not sexually active. The patient denied a history of sexual activity, stated that he was employed as a restaurant host and worked as a hospice volunteer. The patient denied use of tobacco, alcohol, and recreational drugs. The patient also denied mental health diagnoses and mental health challenges and stated that he usually wears his seatbelt. A physical exam of the patient elicited the following findings: a blood pressure of 120/80, a pulse of 75, respirations of 16, and a temperature of 102.5 degrees Fahrenheit. The patient was measured at 5'9" tall, weighed 140 pounds, and had a BMI of 20.7. The patient was well-developed, well-nourished, but ill-appearing. He was clean-kempt and appropriately attired. He had a distinct streptococcal tonsillitic odor to his breath, was cooperative, and was awake, alert, and oriented ×3. The patient's face was flushed and moist. He had no vesicles or ulcers on his palms or soles. The patient had no rash and no symptoms of jaundice. A physical examination of the patient's head revealed no abnormalities. An examination of his eyes, no conjunctivitis, excessive tearing, or discharge. The patient's auricle, ear canals, and eardrums were without abnormalities, and no ear discharge was noted. The patient's nasal mucosa, septum, and turbinates were without abnormalities, and no discharge or sneezing was noted. The patient denied frontal and maxillary tenderness on palpation. The patient's lips, oral mucosa, gums, and tongue were without ulcers. Palatal petechiae were noted, as were enlarged edematous beefy red tonsils with exudate. The patient's pharynx was inflamed but without lesions. No cough or hoarseness was noted. An examination of the patient's neck revealed enlarged anterior cervical lymph nodes that were tender on palpation. The patient's posterior cervical nodes were non-palpable and apparently non-tender. The patient did not respond when this provider palpated the posterior cervical node area. No masses or unusual pulsations were noted when the patient's neck was examined. The patient had normal S1 and S2 heart sounds with a regular heart rate and rhythm. No murmurs were noted on auscultation. The patient's costovertebral angle was normal with symmetrical expansion. No dyspnea, adventitious breath sounds, or cough were noted. A physical examination of the patient evidenced no splenomegaly, hepatomegaly, or tenderness. The patient was without axillary or inguinal node abnormalities, and no back or scapular region tenderness was reported on palpation. No mental status abnormalities were noted on physical examination of this patient. A number of differential diagnoses were noted or were identified in conjunction with the presentation of this patient, including his symptoms and history. Differential diagnoses are noted on the slide, and pertinent positives and negatives, as well as confounding findings for each of the noted diagnoses, are as follows. For common cold, pertinent positives: irritated throat, headache, and malaise. Confounding findings: the absence of nasal stuffiness, red irritated nasal mucosa, nasal discharge, sneezing, and hoarseness. For tonsillitis, pertinent positives: sore throat, pharyngeal edema, enlarged tonsils, tonsillar exudate, and malaise. Notably, a diagnosis of tonsillitis overlaps with pharyngitis diagnoses. For viral pharyngitis, pertinent positives: sore throat, pharyngeal edema, enlarged tonsils, tonsillar exudate. Confounding findings: the absence of conjunctivitis, ear pain, sinus discomfort, nasal congestion, ulcerative stomatitis, cough, hoarseness, diarrhea, vesicles or ulcers on palms and soles, and the absence of a viral rash. For a diagnosis of bacterial pharyngitis, pertinent positives include cervical lymphadenopathy, the presence of cervical lymphadenopathy, fever greater than 102, sore throat, palatal petechiae, pharyngeal edema, enlarged tonsils, tonsillar exudate, headache, abdominal pain, and malaise. Pertinent negatives: the absence of conjunctivitis, nasal congestion, hoarseness, cough, diarrhea, or viral rash. For a diagnosis of streptal pharyngitis, pertinent positives and pertinent positives and negatives apply. Additionally, for a diagnosis of streptococcal pharyngitis, a confounding finding is the absence of a sandpaper rash. For a diagnosis of infectious mononucleosis, pertinent positives include fever, pharyngitis, anterior lymphadenopathy, malaise, headache, palatal petechiae, tonsillitis, abdominal pain, and confounding findings include the absence of chills, sweats, fatigue, posterior cervical lymphadenopathy, splenomegaly, periumbilical pain, back and scapular pain, mild hepatomegaly, and nausea. For a diagnosis of influenza, pertinent positives include the sudden onset high fever, pharyngitis, headache, malaise, and cervical lymphadenopathy. Confounding findings include the absence of cough, rhinorrhea, irritated mucous membranes, myalgias, and arthralgias. This patient was diagnosed with streptococcal pharyngitis. The definition of this condition is that it's a pharyngitis caused by group A beta hemolytic streptococcus, and the offending pathogen is Streptococcus pyogenes, which evades the body defenses, adheres to the pharynx, colonizes, and secretes toxins that damage patient tissues. Risk factors associated with a diagnosis of streptococcal pharyngitis include age, specifically those who are between the ages of 5 and 15, although this diagnosis is common in people of all ages. Additional risk factors for a diagnosis of streptococcal pharyngitis include exposure, especially within the 2 weeks prior to the onset of symptoms, winter and spring seasons, crowded living situations, the presence of chronic disease, a family history of untreated rheumatic fever, and participation in oral sex. Prevalence associated with the diagnosis of streptococcal pharyngitis includes the following: that 20 to 30% of pediatric patients who present with acute pharyngitis are diagnosed with streptococcal pharyngitis, as are 5 to 15% of adult patients who present with acute pharyngitis. Streptococcal pharyngitis tends to occur in clusters and is more common in the winter and the spring, and it accounts for 1 to 2% of outpatient visits. Common symptoms associated with streptococcal pharyngitis include cervical lymphadenopathy, fever greater than 102 degrees Fahrenheit, absence of cough, and the presence of beefy red tonsils. Differential diagnoses include those that have already been listed. The modified center score criteria were applied to this particular patient's history, symptoms, and signs. A score of 4 was obtained. Based on that score, a rapid antigen detection test was done on the patient. The result was positive. So this patient was, as I mentioned, diagnosed with streptococcal pharyngitis. The patient was prescribed penicillin V potassium 500 milligrams taken by mouth twice daily for 10 days. This patient was encouraged to consider using ibuprofen 200 to 400 milligrams taken by mouth every 4 to 6 hours, with a maximum dose not to exceed 1,200 milligrams in 24 hours and a maximum day use of 10 days. In other words, the patient was not to use ibuprofen consecutively for more than 10 days. No additional laboratory tests were recommended for this particular patient. Patient education included education about his diagnosis, follow-up, and treatment. Diagnosis education included educating the client about the multiplicity of causes that could be responsible for his presenting symptoms. Also, that he may have a fever of 101 to 104 for 4 or 5 days, but that he may be able to expect symptom improvement within the next 3 to 4 days. As far as follow-up education is concerned, the patient was encouraged to contact his provider if he had no improvement in the next 3 to 4 days, or if he had difficulty handling secretions, drooling, had a hot potato voice, toxic appearance, and unilateral neck swelling. The patient was taught that penicillin was the first-line treatment to eradicate his pathogen, and he was encouraged to use analgesics and to use supportive therapies to relieve his symptoms. The patient was also taught that NSAIDs were more effective than acetaminophen in treating pharyngitis. The patient was further instructed that adverse effects associated with penicillin V use include black hairy tongue, diarrhea, epigastric discomfort, nausea and vomiting, as well as significant diarrhea, hypersensitivity, rash, urticaria, superinfection, with candida, for example, fever, vomiting, erythema, dermatitis, angioedema, and seizures. Additionally, the patient was taught that adverse effects associated with ibuprofen use include constipation, diarrhea, indigestion, nausea, headache, and upper respiratory infection, as well as gastrointestinal bleeding that could be evident as blood in the stool, chest pain, skin irregularities, and rash. The patient was also instructed to contact his provider if any of the symptoms shown in this slide in red appeared. Consultation, collaboration, and referral associated with a diagnosis of streptococcal infection may be appropriate when a patient presents with significant tonsillar edema, airway obstruction, peritonsillar abscess, or post-streptococcal glomerulonephritis. Usual follow-up for patients diagnosed with streptococcal pharyngitis is There typically is not follow-up with this, but patients may contact their providers again if they have no improvement in 3 to 4 days, at which time providers might reconsider original diagnoses and possible complications. Additionally, post-treatment cultures and additional rapid antigen diagnostic tests may be done under unusual circumstances, including situations where a provider wants to assess patient compliance or if the patient has a personal history of rheumatic fever. Encouraged for this particular patient by the U.S. Preventative Task Force services include screening for alcohol misuse, depression, high blood pressure, and HIV. Disease prevention associated with streptococcal pharyngitis diagnosis includes contact avoidance, especially avoidance of contact with infected others, hand washing, especially during cold weather months, the avoidance of utensil and cup sharing to avoid bacterial transmission, and prompt treatment of those with a family history of rheumatic fever. Disease prevention efforts associated with streptococcal pharyngitis also may include the use of probiotics and interferon alpha streptococci. Also an awareness in the community and amongst patients that they can get this infection again, that reoccurrence can be a reality for them, and that complications of a streptococcal pharyngeal diagnosis may be prevented if penicillin administration occurs even 9 days after onset of symptoms of rheumatic fever. Routine testing and empiric treatment of asymptomatic family contacts and prophylactic treatment of siblings is not generally recommended. Treatment guidelines recommend supportive care, antibiotics, analgesics, corticosteroids are not recommended, nor is tonsillectomy. Patient education is encouraged, particularly the forecasting of the disease course for patients. Backing up here a little bit, supportive care encouraged by treatment guidelines or identified in treatment guidelines encourage sucking on hard candies and lozenges, the use of gargles, soft foods, cool liquids, increase in fluid intake, toothbrush exchanged at the close of treatment, humidification, the use of oral sprays and rinses, and the use of analgesics and antipyretics. And as I mentioned previously, antibiotics are recommended in treatment guidelines, include the penicillins, cephalosporins, clindamycin, and macrolides, with penicillin V being the first-line treatment for streptococcal pharyngitis. As you can see, I've included a prescription here for a diagnostic test, specifically the rapid strep test, and symptoms that support a rapid strep test prescription include the presence of sore throat, fever, and tonsillar exudate. I've also written a prescription for the patient for penicillin V, potassium 500 milligrams, with instructions to take 1 tablet by mouth twice a day for 10 days. And the patient will receive 20 tablets with no refills. Here are my references. And with that, I'm not sure if you can see me, but I will close my presentation. Thank you.